Can see that.
Brilliant. Okay. Those that came last time know that I'm Jill Kilbury, and this particular session is how we do the payments across the NHS, how we pay for things. Not sure why that hasn't come up quite properly on the slide, but never mind. Hopefully the rest will. These sessions are recorded and they'll be uploaded to the learning portal after the live session. Just gives you the flexibility, which obviously some people are making use of tonight. Do remember, listen to what we talk about, take your own notes, think about it, do your research and ask questions. You're more than welcome to ask questions. Sorry? You can't hear me?
Someone's just come in and I think it's a bit of background noise.
Okay, and just bear with me while I shut the...
No, not from you, Joe, from the person that came in.
Right. Oh. You're more than welcome to ask questions in the chat or post this session. Please do use the forum on the portal. Make sure that you ask anything that you're worried about. We will get back to you. And before you complete your assignment, remember to plan what you're going to do, reread your notes, write it out, read it again, edit it and rewrite it. Give yourself time to do it. This session, we're looking at the development of the payment system, trying to understand the process, how the money the providers get is calculated. We will be talking predominantly about England, but we'll start from the basics and work forward. Quick reminder, how the money flows through the NHS. So we've seen this before. It comes from the Treasury to the Department of Health and Social Care to NHS England. NHS England then passes a large amount of that to ICBs, but pays for some specialist services itself. ICBs pay providers for the main healthcare required by its population. This is just England. When we look at the devolved nations in another session, you'll see the differences. So the big question we've got today, in an environment where we've got limited money, how do we make sure we get the right amount of money in a fair and transparent way to the providers that provide the healthcare services? To do that, we need a method of calculation and a method of transfer. And that's what we're going to look at. We talked about ICBs last time we met. They are the NHS bodies whose main statutory duty is to agree on the care needed for patients, including allowing for choice, negotiate the contracts with providers and monitor contract implementations. So additionally, they're responsible for managing finances within limits. So they have a budget they have to keep within. They're monitored and checked on by NHS England, and they try to ensure financial balance. But they also need to promote innovation and health services and equality. I said we won't be talking about devolved nations today. That's for you to do the research and to join in the next sessions we've got. The size of the devolved nations makes their systems much simpler than England. They can be simpler because they have fewer organisations to deal with and fewer people. So, most of the providers in the NHS services are NHS organisations. So why can't we just have a gentleman's agreement? We're all the same family after all, aren't we? The money comes from the same places. Well, yes, we are all the same family, but we are all individual legal entities with varying statutory duties operating with our own legal frameworks, which means we need to have formal agreements. Those agreements have got to provide clarity on what's being provided and for how much. They've got to show responsibilities of both parties. And of course, they've got to show what happens if something goes wrong or there's a dispute. If you think about it from things you might get involved in yourself personally, you wouldn't buy a house on a handshake, even if it was from a member of your own family. You wouldn't go into partnership with your best friend without some sort of written agreement. Would you leave it to trust that paying over money now for something you expect to get in 3 months' time will be fine? We wouldn't do these things. And neither do we spend millions for healthcare services without some sort of legal agreement. So a healthcare provider is a legal entity, or it's a subset of a legal entity. You can have 2 or 3 providers linked to one legal entity. And they provide services through NHS contracts. Got a quick poll for you. There are lots of different sorts and sizes of healthcare providers, but the one that we know most about, or we see most often, are NHS trusts. And I'd be interested to know if you have any idea about how many NHS trusts there are within England. I'm hoping Chloe's put something up in the poll.
I have launched the poll.
You have launched the poll. Oh, please do answer. Shouldn't take us long. We haven't got many of you.
I've had 8 responses so far. Just changing. So I've had just one person, I think. Someone's just asked the question, said, does this include NHS Foundation trusts?
It does, yes.
I think that's everyone. So we have 36% of people went for A, 36% of people went for B, and then 27 went for C.
Okay. Well, depending on where you look on the internet, you can get answers anywhere between 202 and 215. But it is changing regularly. Now, these are the trusts themselves. Trusts can have 3 or 4 hospitals within them. So we're not talking NHS hospitals here, we're talking the trusts themselves. So just over the 200 is what we're looking at. That's quite a number. But there are lots of different sorts of NHS providers. We've got foundation trusts that have just been mentioned, and we've got NHS trusts. So NHS trusts were allowed to apply for foundation status back in April 2004. Foundation status gives more managerial and financial freedoms than NHS trusts. Over the last few years, it's been a bit debatable as to whether it was worth anything extra, but we're expecting that to change over the coming years and foundation trusts to become more and more popular again. Of course, acute, mental health, ambulance, even community services can be foundation trusts as well as NHS trusts. We've got GPs who are independent contractors. Now, they can be structured in a number of different ways. They can be partnerships, they can be companies, or they can be groups. Over the last few years, we've even had some vertical integration, with GP practices being owned and run by community or acute trusts. Community service providers, they're the health visitors, district nurses, therapists, etc., but they're really the trusts as well. We've got independent sector providers, organisations such as Bupa, Nuffield, Spire, and then dental, pharmacy, opticians, who provide NHS services as well as paid services from the same place. Third sector are those not-for-profit organisations that operate outside the public and private sectors. They're voluntary organisations, charities, people like Age Concerned, Mind, British Red Cross, Young Minds, people like that. Both NHS England and ICBs must use a competitive and formal process to secure health services from providers. They've got to have contracts. We don't have a choice. The NHS and independent sector providers can all compete for contracts to provide national and local services. It's not absolutely given every time that a contract should go to an NHS organisation, although that is better now than it used to be. There is still bidding for contracts and tenders are expected in an awful lot of circumstances. But there are two main contracts that we can use in the NHS. There's the GP contract, says what it does what it says on the tin, and it's for GP contracts. And there's the NHS standard contract, which is for everything else.
So just before you go, I've had a question, Joe, if you don't mind.
Oh, yes.
Next bit. So NHS National Blood and Transplant are a SHA. So are any other arm's length bodies a healthcare provider? Trying to think of any, but it seems like they're mostly corporate services.
They don't tend to be. I can't think of any others offhand. But if you remind me about that, Chloe, I will look it up afterwards, but I can't think of any others offhand.
No, Mark, I'll note that down and then I'll get your answer back.
They have to be different. Okay. Okay. So GP contract. It's specific GP contract documentation that's going to be used for GPs. For general medical services, GMS. As we've said, GPs are usually independent organisations. There are some that have been vertically integrated, but vast majority are some form of independent organisation. The GP is not employed by the NHS. The GP contract has some things in it which are mandatory. We usually refer to them as core, and other elements that the practice can choose to provide or not. It's enhanced services, is what they're generally known as. The capitation element referred to in the slide makes up core funding, and it's based on the number of people registered with the practice. That basic number is adjusted depending on the age and sex profile of the people who are registered, as well as the disease profile of them and local deprivation. It's not based on the amount of care that's actually given to the patients. It's a calculated figure based on capitation. Enhanced services, for which there's a national price, are laid out in the national contract and known as directed enhanced services. These are things like flu vaccinations, minor surgery, care of the homeless, lots of different bits and pieces that if a practice signs up to doing, they will get paid to do. But there are also other bits and pieces that are paid to GP practices. Some of these are in the form of reimbursements. So practices get reimbursed for premises rents and rates and water bills and clinical waste collection. All that sort of thing is reimbursed. The payments are made to the practice. They're not made to individual GPs. The other one is the standard NHS contract. The template for the standard contract is provided by NHS England. It's updated annually and it must be used. So why should we have a standard contract? If you remember, these are legal documents. The time and effort, as well as costs that would be necessary to be able to produce a legally binding contract with a number of providers that an ICB contracts with, or a provider contracts with the number of different ICBs and different commissioners, it would be huge, because these things have all got to be legally binding. So you need to go through them with an absolute fine-tooth comb. But if we have a standard contract where the whole country knows those clauses within it, what's expected of them, what it means, what's going to be changed year on year, everybody's delivering to those same standards, it takes a lot of that admin, that time commitment, that legal issues out of our hands, really. We have to use the standard contract. We all know what's included in it, and we can all work to those standards, regardless of who that provision is being given to. So a provider is using the same standard contract for all the people it's providing services for. Makes it much simpler and much more streamlined. Within that contract, you've got three parts. You've got the particulars, which have got your activity levels and the contract prices split into fixed and variable. We're going into that later. Oh, sorry, I've got pressed the wrong button. Going to that later. You've got the service conditions. So these are the clinical services and terms, what it is you're going to provide and to what quality. And then you've got some general conditions. These include termination and renewal terms, definitions, dispute resolution processes, that sort of thing. Okay. And what providers get paid is as per that contract. So we've talked about the fact that commissioners are the ICBs in the main, plus NHS England slightly, all using the same sort of contract. But an ICB could have upward of 200 contracts with NHS providers alone for NHS care. That doesn't include things like continuing healthcare and personal budgets or primary care contracts. That's an awful lot of contracts. ICBs commission their services for their registered population. So the people who are registered with GPs within their geographical boundary. Plus those that aren't registered with any GP but live within their borders. So if you live within one ICB's area but are registered with the GP in a neighbouring county, say, you may be the responsibility of that neighbouring ICB because of who you're registered with. Specialist providers are dotted all over the country. Not every ICB will have a specialist hospital, for example, children's specialist hospital, within its area. It may have some specialist facilities, but it might not have a large hospital. Specialist centres are designed to cover a wider area. Things like, think about Alderhay, based in Liverpool, or Great Ormond Street in London, or Birmingham Children's in the Midlands. They're all really big children's facilities, but you haven't got one everywhere. You've got a few really specialist places. So every ICB would be contracting at some point with specialist centres outside their area, as well as hospitals within their area. Okay, so where we are now. Oh, I've done it again. Keep pressing the wrong thing. So commissioners make payments against the NHS standard contract on the same day every month. This gives certainty to the provider, knowing that they'll receive payment, when they'll get it, and it reduces transactional costs as only one payment is processed by each ICB for a provider. What that payment comprises of depends on the approach taken for the contract. Standard contract incorporates an aligned payment and incentive approach, a low volume activity approach, activity-based payments, and local payment arrangements. These are all variations, but they're all contained within that one contract. You have the options to do these within the contract. So let's have a look at the aligned payment and incentive approach. This is the main form of the contract where there's a reasonable level of activity being provided to the ICB's population. This is the main thing that's done. And it's done with all NHS commissioners and providers. It's got two elements to it. It's got a fixed element and it's got a variable element. The idea of the variable element is to reflect the changes in volume compared to plan. So the fixed element represents a single amount to cover the expected costs of all services provided under the contract. The total contract value should reflect the cost of the planned contracted activity, plus any other services that have been commissioned. Most elective activity is variable, except outpatient follow-ups. This is to encourage increased activity to reduce waiting lists and shift to best practice processes. An incentive approach. Emergency care services, although part of the fixed element, are also subject to activity monitoring. Where activity is higher or lower than planned, a 20% adjustment can be made. So you get a contribution towards the cost. Mental health and community contracts are mainly fixed cost contracts. They're mainly blocks because of the lack of robustness of activity data, but that is changing. Contracts with the independent sector are all variable. You do have some flexibility in how you calculate a fixed cost, but it's based on national prices where they're available. A low volume activity approach. This is where a contract has a value of less than 1.5 million with an NHS organisation. It's calculated nationally and it's a one-off payment that's made around Q2. It doesn't change regardless of activity in year. The value of the activity done through the contract is monitored nationally and locally, and it changes based on a 3-year average. As with everything else, the prices that activity is calculated against change with cost and efficiencies. But it's a nationally calculated value, agreed to through a spreadsheet, not through a full written contract. The full written contract is assumed based on that spreadsheet. So each ICB will have a spreadsheet with all its LVAs on, nationally given values, and it pays them once a year, one total amount. That covers, to a lot of extent, all those small contracts where people go off on holiday and something happens to them as an emergency. Those tend to be the sort of contracts that are less than 1.5 million for an ICB. Previously, before we did it like this, those providers will have had to bill for each individual person. Got that agreed with the ICB and waited for the payment. Very complicated, very time consuming, very admin consuming. This way is much simpler, takes out a lot of the risk with small activity base. No invoice is needed. It's paid on a national amount. Non-NHS providers such as Bupa or Spire usually focus on elective care. Once contract's in place, it is available for patients to choose. So for quite a lot of day cases, cataracts, that sort of thing, patients can choose where they want to go. And non-NHS providers provide an awful lot of that sort of activity. Low risk, high volume, mainly day case.
I've got a question when you're ready.
Yeah.
So just to clarify, the value of the individual transaction being less than 1.5 million, or is it the total of all of the transactions for that activity being less than 1.5 million?
The value of the activity between a particular provider and an ICB for a year is less than 1.5 million.
Mm-hmm.
That answer the... Is that okay?
Hopefully. Yep, nothing else. Mark's just writing back. He said yes, thank you.
Brilliant, lovely. Okay. Yes. Right, so yes, the resulting... So patients choose to go to non-NHS providers when it's convenient for them, usually for the, as I say, for the low risk day case type provision. Invoices are raised monthly and are reconciled against the activity data through SUS. So non-NHS providers still have to provide their activity data into the national system. They're still under the same NHS contract, but the fixed element of that contract payment is zero. They only get paid on the variable. And there's normally national prices for these things that they do. So the activity times the national price gives them the payment, but it needs to be reconciled. There is one other thing on these ones that I will just mention. When a non-NHS provider has a contract agreed with a NHS commissioner, it's very difficult for any other commissioner not to have a contract with that provider. They may not, people might not go, but if a patient finds that particular provider on some sort of choice and chooses to go there, because there is an NHS contract in place, they can't say no, or they will find it very difficult to say no. Local payment arrangements. This is when nothing else really fits. Okay. It's local priced activity, but it can be included in the standard contract, and it should be. Depending on what the service is, either sits in fixed or variable, depending on what it is that's being provided. But these are things where the national price is either not in existence or not relevant. So the method of paying has to be agreed between the commissioner and the provider. Still under the standard contract, but with slight differences. For example, an ENT outpatient procedure could be carried out in an acute hospital and be payable at the national price. However, the same procedure could also be carried out by a GP specialist in a practice clean room or community hospital. The commissioner may negotiate a discount off the national price with the GP specialist due to the reduced infrastructure needed, because they're not doing it in an acute hospital. The fact that the GP premises are already paid for under the GP contract or other factors like that will also affect the prices that they're prepared to pay. So we don't always use the national prices. There can be some local negotiation. So our original question was, how do we get the right amount of funds fairly and transparently to providers who provide healthcare services? So we've looked at how we get the money to providers. Basically, you've got the two contracts. But how do we calculate the right amount of money a provider should receive? We're going to have a look at that next. So how the national price is set. There's a national cost collection exercise. So first place, it goes back to what the actual costs of provision are. And all providers provide information to Central on an annual basis. At some points it's been quarterly. It used to be called reference costs. I think PLIX has been used, but it's now called the National Cost Collection Exercise. The information that's collected and then used to produce costings for the following year. So it's always at least a year out. Prices set using this data are an average. That means there'll be winners and losers. It's important that provider submissions are as accurate as possible, otherwise it can really derail the process, make it not worth the paper it's written on. So the more accurate costings can be, the more accurate price, the more reasonable prices can end up as. Those average prices are then tweaked. So in some cases, the push is to move activity from inpatient to day case. So the price for an inpatient may be reduced slightly, and the price for a day case may be increased to incentivise the transition. There could also be changes for technology that it's known nationally will be coming in the future year. So processes may change slightly, which may increase or decrease the costs. There's also the cost uplift factor, which is applied to the prices that are calculated from the averages. The CUF, that's known as. And this, in effect, is the inflationary. It looks at new things coming in, inflation, technologies, techniques, but it also applies that efficiency. So, for example, in 23-24, a CUF was set at the start of the year. Prices were increased by a certain amount. But that changed mid-year when a nursing pay increase was agreed. And it changed again later in the year when the consultant's pay was agreed. So the prices used at the start of the year weren't the prices that were being paid by the end of it. If a provider has a service which uses very little in the way of technology, equipment or drugs, but a lot of staff time in comparison to another provider providing the same service, then the average CUF increase may not be sufficient to cover pay inflation, because pay is the big inflation factor. And if you've got a service that uses huge amounts of pay, huge amount of people, but not much of the technology and equipment, that inflationary increase isn't going to cover all the staff that are included. CUF is always an average. So it's looking at the whole services, giving you that sort of increase. So when providers are given their CUF increase on their total contract, they may not be applying the same increases across all different services. That inflation may not be applied standardly across all its services. Same applies if you've got a drug of choice, which is going up in costs far more than inflation. Providers need to consider what they're going to do in circumstances where they've got that disparity? Do they do that manipulation across their services and do more for this service, less for that service on inflation? Or do they look at what they can do to bring their services back within that average? It's a choice. If you've got an elective service, which is delivering more for the same, if you've got an elective service, then delivering more for the same money will deliver efficiencies, because elective, as we said, was in the variable element of the contract. However, if the service you're providing is part of the fixed element of the contract, only reducing the costs associated with planned activity will deliver the efficiencies in year. So you're delivering your service. There's an expected efficiency built into that cuff. If it's an elective service, then you can deliver more for the same money because you're going to get paid more for the more activity that you do. If it's not an elective service and it's a service that's based within that fixed element, you're not going to get more money for delivering more activity. Therefore, to make your efficiency, you need to reduce your costs. Payment approaches have changed quite a bit over the last 20, 30 years, as you'd probably expect. As with other things within the NHS, as governments change, as ideas change, then we change the way we do things. So pre-1991, I know that's going back a long time for some of you, we had block contracts. But as you said, we've still got almost block contracts for some areas now, depending on what it is we're providing. They've always been there, but they're far less than they used to be. Everything used to be on a block contract. We had a thing called GP fund holding, which gave GPs the power to be the commissioners, and they purchased elective activity on a piece-by-piece basis and were billed for each individual bit of activity. From that point on, we started to try and understand the cost of services. This is where you've got your reference costs coming in. Nationally, trying to look at how much things actually cost us to deliver. That allowed the development of health resource groups and eventually payment by results.
Just want a clarification on what elective and non-elective means and how it relates to contracts.
Okay, so elective work is things that are planned. It could be a hip replacement that's been referred in by a GP, gone for an outpatient appointment, been put on a waiting list, treated, and then come out. Now, you can have a hip replacement that's non-elective because if they've gone in after an accident and that's broken the hip, it's had to be replaced. So the elective things are things that are planned, usually referred in by a GP or other clinical responsible person, the activity undertaken, and then they're discharged. The non-elective, there's a slight difference between emergency and non-elective, because maternity could be classed as non-elective, but it's non-emergency. An emergency are your things that go through SDEC or through A&E or through emergency care centres. That's their way in. Does that help?
Yeah, understood. Thank you.
Lovely. Okay. The idea that elective, that non-elective things are within the fixed sum is that a provider will have to have a certain amount of people in their organisation, a certain infrastructure set up to deal with what their standard expectation is for stuff just walking through the door. So they're paid for that standard. Therefore, it's not, if their people coming in through the door goes down, then they're not penalised for that, apart from this 20% if it goes across past a cap. Whereas elective, people are referred in, they're on waiting lists, and the provider is in control of how it's bringing those people in. And the push is to get as many people off those waiting lists and through and cared for and back out the other end. So they are incentivised to get them through, which is why it's the variable element. Not sure whether that's just confused you more or helped, but we'll go on. Okay. The development of health resource groups was introduced as a means of simplifying activity costs. So rather than having a price for every single different sort of activity, a health resource group bundles them together. And payment by results was the way that nationally we moved towards those national prices. So using those healthcare resource groups activity data to produce a national price where we could assume a level of efficiency and incentivise best practice. And after payment by results, of course, there came the national tariff, which is what we use now. So pre-2000, I've said, block contracts, simple and sophisticated, there were no incentives in them. GP fund holding was an idea of where the money follows the patient. But it was abolished because it was seen as a two-tier system. So patients who were registered with GP fund holding practices were able to access better, faster care than those registered with practices that weren't in the scheme. The GPs had more influence, therefore their patients were seen quicker. They could go elsewhere. They didn't have to use, they could use the private sector if they wished to. If anyone's going to influence the elective activity completed by hospitals, it's the GPs, because they send in the referrals. The majority of patients for elective come via the GP into acute care. By not including non-elective, the emergency stuff, within that GP fund holding, there's incentive for the GPs to not refer patients and wait for the patients to be admitted as an emergency. That's why they brought in a thing called total purchasing pilots. I know about that one because that's when I came in. Awfully long time ago. But then in 1998, we got primary care groups, which were groups of GPs brought together to manage larger areas. They used the principles of fund holding to some extent for larger populations and geographical areas and incorporated all care. So from 2000 onwards, HRGs were first developed in the 1990s, but it wasn't until 97 with the development of HRG version 3 that they became reliable enough to be used for the quantification of resources. In early 2000, government reforms meant that money for healthcare services was needed to follow the patient. talked about following the patient, both to allow for patient choice in where they went for their treatment and to reimburse the provider delivering that care. This resulted in the first payment mechanism, payment by results, replaced the previous practice of making block or fixed payments to healthcare providers. Costs started representing the complexity of the work that being supplied. So payment by results was introduced in 2003 using HRG version 3, with the aim that by 2008 it will cover all healthcare services. Every unit of activity was captured and charged to the commissioner, so providers were paid for the activity they delivered. Didn't matter whether it was elective, non-elective, what it was all captured and charged. Prices were calculated by Department of Health and were applicable to all providers of NHS care. Of course, there were things that there wasn't a national price for, and that had to be negotiated locally and agreed between commissioner and provider as to how much they'd be paid for specific things. As you can imagine, that led to an awful lot of disputes. I'll talk about those later. While the same HRG could be assigned to patients admitted either electively or as emergencies, the cost of the treatment would be different, and different prices apply. There are around 4,000 different HRGs. There's a lot riding on how providers code their activity. Different coding can result in different resource groups. Depends where it sits. It looks at diagnosis, it looks at interventions, it looks at where the patient has moved from and to. They're like strings, HRGs, a bit like your DNA. So many different elements, so many different choices. Put them all into one string and out pops your HRG. But just changing one of them can change the HRG that something sits in. Can increase the cost of it, maybe decrease the cost of it. Attract a best practice tariff. They contain elements which distinguish the individual. So not all spinal surgery is the same. The HRG will be different depending on the technique used, fusion or decompression perhaps, or the presence of comorbidities. Did the patient have osteoporosis, or has they had previous surgery? Those two change things. These all impact the resources needed to complete the treatment, absolutely. You've got the length of stay, that can be more complications, can make somebody stay in longer, time in theatre, the experience of the clinician, medication or other equipment needed. These all impact what it is, what is the cost of a particular procedure. So all these things are taken into account when an HRG pops out as to how much a provider should be paid for it. Day case, inpatients, elective, non-elective, all have different codes. Outpatients split into first attendances, follow-ups, non-face-to-face with procedures. Ambulances get the same pound for each patient they bring into the hospital. You'll have seen over the last 4 or 5 years, plenty in the news about ambulances waiting outside hospital for hours. The tariff pays the same whether the ambulance is waiting for the standard 15 minutes or 4 hours or over. It's a price for bringing them in. There's new HRGs being looked at now, which relate to mental health and neurodevelopment. Some of those are in use. They're still being monitored and looked at and developed. They don't cover all mental health, but they cover more than they used to. And the community currency is in development. So lots of activity data and costs are being submitted regularly to national databases to help make sure we can gather a community currency that is usable. But it's early days on that one. When we've got PBR, income could be increased by a provider by either changing volume or cost. Cost reduction could result in lower quality, but patients had a choice as to where they were treated, and therefore you can't drop that quality too far, otherwise patients wouldn't choose to go to that provider. However, the majority of patients will always choose to attend their local hospital. They won't all be willing to move just because the quality doesn't appear to be the same. Disputes often arose regarding changes in coding. So there's a fixed price per HRG, but if you switch what codes you put to it, the HRG changes and the price changes. Plenty of disputes between provider and commissioner on upcoding, changing how you're coding the activity that you've previously done to push it into a different HRG and to a different price. Sometimes at the end of the year, there'd be tens, hundreds of millions of pounds in dispute because of things of changing codes. Wasn't a simple, straightforward. You'd think it'd be simple and straightforward, wouldn't you, to have a fixed price for a particular amount of activity? But it led to huge amounts of issues. There's also the fact that each organisation still had to live within its means. If prices for activity went up within a contract and the commissioner only had limited resources, how's it going to pay for that activity? One or the other of those two organisations is going to come off worse. That was part of the problems of PBR and that payment for everything individually. The other issue was that by 2012, PBR only covered 60% of acute hospital income. If you think back to what I said a couple of slides back about the intention was that everything would be covered by 2008. Missed that by a long shot. Mental health, community and ambulance services were severely lagging behind and still are due to poor quality data. The thing about those sort of activities and those sort of providers, the mental health community, it's not always simple to judge what activity is going on with a particular patient. It happens out in the community. It's not in a nice ward where they could get access to a computer potentially to record what it is they're doing. A lot of the data is collected manually, which meant it's difficult to consolidate quickly. It was written in a huge variety of formats and not consistently maintained. If there were 200 trusts providing community or mental health services, then there would be 200 different ways of recording it. Not easy to be able to collect that into a national data set that everybody was going to actually complete properly. The Health and Social Care Act in 2012 renamed PBR to the National Tariff. There's now a legal process around that tariff's development, which included an annual consultation period.
Just got
So
a
the
quick
tariff is,
question while you're
sorry?
on. I've just got a question while you're on PBR. From Victoria, she said, "Is it quality of data, or because they have shut the mental health services / homes, etc.?" It came through just as you were finishing the previous.
I'm sorry, what, quality of data or what?
Or because they have shut the mental health services / homes, etc.
Okay, no, it was because of it. It was difficult because of the way organisations collected data themselves, both in terms of how it was, what elements of it were collected. Was it the amount of time somebody was spent, a clinician spent with somebody, or the number of times they were visited, or whether they were what place they were in, as well as the fact that a lot of this was handwritten, and it's easy to lose a page or to misread somebody else's writing. So the data was not of good quality because of the way it was collected and because of what elements of the data were collected. That's why the tariff has been very difficult to come up with. Okay. So we've now got a national tariff and a legal process for its development, including consultation. So each year you'll see a consultation comes out as to what national tariff is going to be used. And HFMA and other people like that all club together and put in responses to it. Individual organisations will have a look through what's being suggested and will pass comment on it. You have the opportunity to do that before the final one comes out each year. So the national tariff has a couple of options. You've got a national currency. It is a national currency. And for a lot of things, it's got a national price. It's similar to PBR in the way it works, but it's not for everything. The amount paid to the provider is taken from the national price lists and depends on the treatment that's planned, whether it's an emergency as well as the treatment that's received. You can have local modifications. So you can request to NHSE for a local modification to a national price. It's rarely used because you do have to plead and you have to jump through a huge amount of hoops to get anything changed. But it is available if you can make the case. You can have a national service, so something that's provided frequently across the country, but a local price. So these are services that have never had a national price. Again, things like the mental health, the ambulance services, things that everybody uses, but there's not necessarily a national price for it because we're still in the process of calculating what the real costs are and how we can make it so that we're not having a price for 100,000 different ways of doing something. We need something that can reduce those so you've got a manageable process. So there will be, for a lot of these, a national currency, but the price and payment is negotiated locally. To have any local approach, it's got to be in the interests of patients. It's got to promote transparency and best practice, and it's got to be based on constructive engagement between provider and commissioner. Those three elements have got to be there, and they've been consistent over the years that the national tariff's been around. We do still find that mental health community services, at least a good proportion of what they do, is often retained on a block contract. We are trying to move away from that. We do encourage quality. So there are best practice tariffs. Right. These were introduced in 2010-11. So they've been around a long time, but there's more and more coming in each year. Things like that movement from inpatient to day case, or from day case to outpatient. You'll get more money for doing it in what is considered to be the best way. Okay? They're there to reward delivery of high quality, cost-effective care. And it's aimed to incentivise the movement. Things like a stroke patient's pathway. If they follow the best practice pathway, the provider gets more money for it. There's a maternity pathway as well. They're set higher than the standard tariff to incentivise that adoption. And of course, any sensible provider would want to generate as much funding as they possibly can from doing things. And it's far easier to have one standard process than a number of them. You don't want to be doing this for odd ones. You want to be applying that best practice for the vast majority of your patients.
Got another question when you're ready.
Mm-hmm.
So, are the national prices and the local prices published? Can I go look at the ICB and see they have a rate of X that is higher / lower than the national rate?
National prices are on the NHS England website. They're all there every year, along with a copy of the standard contract. So everything's there that you can have a look at. Local prices. ICBs, I believe, are expected to publish their local prices, but they might be hard to find. Your best way of doing it would be to pick a couple and ask if you were trying to do some research.
Sounds like I might have a play with Excel then and see what he finds.
Yeah.
Yeah. Perfect.
Okay. Okay. The Commission for Quality and Innovation, CQINs, these were again introduced in 2009-10. So they've been going a long time. They're linked to the contract, and they're for specific initiatives. So you get a CQIN payment for doing particular things, and some of them are national requirements, and some of them are agreed between the commissioner and provider, generally for the benefit of both. They've been currently paused, but they will come back in. And they're there for providers to deliver clinical quality improvements in the main. They're not always linked to things that you would get paid for. So they may be, at one point, one of the national ones was to do with smoker cessation assistance for patients. So if somebody came in, a smoker, then the acute hospital would provide some sort of smoker cessation assistance and signposting for that person when they came in to try and get them to do it fully, engage fully on their release, on their discharge, and maybe even start while they're in. So it was those sort of things that is really good to do, doesn't generally generate any additional funding for the provider, but is something that's the right thing to do. So the payment mechanism itself has changed over the years. It got really complex and really complicated, very sophisticated, encouraged lots of arguments to actually get money paid across, tended to make things more complicated in the end than they actually needed to be. Regardless of how long we've been trying to do the payment process and cover all our activity, we're still not there. Okay? We're not covered by all NHS services. It's not been achieved. The things have got steadily more complicated, as I've said, to the point where we had to do something to change it, which is what we're trying to do at the moment, which is why we've got the tariff and the contract set up that we have now. So we've got a fixed and a variable element to try and get rid of some of that complexity and that contractual challenge. As I've said, payment by results, national tariff, and then we've moved from block through to where we are now with the different way of looking at fixed and variable. So I'm just conscious that I've been going quite a while now, haven't I? Okay. The PBR encouraged competition. Providers operated very separately to commissioners, very different organisations, not very much joint working, and that caused the friction. All NHS providers were financially incentivised to become more efficient, but any provider whose costs were less than the unit amount they were paid was financially rewarded. So if you could bring your cost down to less than the price, you'd get more money for it. More money would be pulled in to acute hospitals. But we only have so much money. The demand for the NHS continually grows. We see people, we want to treat them quicker, and that's a good thing, isn't it? We want to get people through the doors, seen quickly, treated and out. But where more people being seen and treated results in more money being paid out, we've got to have a limit because we only have so much resource. Those behaviours encouraged people to be dragged into acute hospitals rather than be seen in the community. So if you go back, community and mental health were mainly on blocks, couldn't increase their funding, whereas acute hospitals were being paid for everything that they saw. People being dragged in because that acute hospital got more money for every single person it saw. Didn't help holistically. One referral wasn't seen. If a referral comes in and that patient will be seen for that particular thing, they would be sent back out to be referred in again if something else was thought to be needed. That holistic approach wasn't there or wasn't encouraged. They were often passed between specialties, duplicating attendances. People got out very quickly, if at all possible, which is a good thing. But may be admitted overnight, so they got an inpatient stay rather than day case. We've talked about coding creep. So these are always the things that made that get far out of hand financially and quality wise. We had the pandemic that struck us. During that pandemic time, June 2020, 2021, everybody went on a block contract. There was a fixed amount of money available, and it was based on how much a provider needed to operate. Simple as that for a start. So everybody got what they needed. But blended payments were the next way forward. And this came in 1920 for the second half of the year for emergency care services and for some mental health. Again, this is the fixed amount and the volume related payment. So this was the start of how we are now. We were looking at a fixed amount based on expected levels of activities, actually contracted, planned activity, and a volume relating to actual performance. and to incentivise delivery of quality. The idea at that point was to move the activity to a population-based payment. So rather than for looking at individual in and out of the hospital, but to look at what your population would need for a year. That was ambitious stuff. The aims of the payment schemes that we have now and as set out in the Health and Care Act 2022 is that they must be in the best interests, transparency and good quality, engage constructively with providers and commissioners, reduce health inequalities, and follow the operational guide. Supporting better health by reducing inequality is the key aim for the NHS at the moment. The guidance states that when agreeing payment arrangements, commissioners and providers must ask how the agreement could facilitate equitable access for seldom heard population cohorts. It's written into an awful lot of what's going on now in the contracts, in the 10-year plan, trying to reduce inequality. And finally, we've gone through 3 distinct phases over the last 26 years. We've had payment by results, we've had the national tariff, and now we've got the national payment scheme. We got more sophisticated, more complicated, and now we've tried to bring it back to deliver that focus on care and quality and accessibility. We've had the Health and Social Care Act 2012 and the Health and Care Act 2022, which have both had impacts on what we do and payment mechanisms. And how we get paid for something impacts our behaviour when we're providing NHS services. It's bound to. We need money to operate our hospitals, our community centres, pay our staff. It's only natural to want the most money possible to deliver the best quality stuff in what we do. Therefore, how we get paid influences what we do and how we do it, where our focus lies. Which is one of the reasons it makes finance in the NHS so important and so key to how we work as an organisation, as a system, as a country in delivering our health and care. The payment scheme that we've got at the moment is trying to use the best parts of what's gone before to support that joint working and improve the health of our local population. But it's difficult and it needs us all on board to be able to do it. Okay, so that's me finished for today. You'll be very pleased to hear because I've gone over again. I don't seem to be able to keep it to the time. You won't hear from me again until study week 10 when we talk about devolved nations.
Yeah, and just to say, it's the wrong date on there.
It is.
Because I put that in and that was the old one. So I apologise to everyone on the call, but you've had an updated Teams meeting into your diary. It's on the Tuesday instead, which is the 2nd of June.
Yes, my apologies. Clashed with my holiday. But I can't change.
No issue.
Thank you. There is plenty of information out there on the web on this particular subject. There is loads of stuff you can look at. NHS England, King's HSJ, HFMA website, lots of stuff out there, but do also talk to your own organisation about what goes on within your setting and how the payment system affects your trust, whatever it is that you're working in. Okay.
Perfect. And we'll probably we'll finish up there. And if you do have any questions, as Jill said at the beginning, please post them on the learner questions, or you can email me on the Academy, and I can pass them through. But thank you so much. I will stop recording.
I will stop sharing.